For 12 years, she was just the quiet night shift pharmacy tech in a blue coat, counting pills and filling prescriptions. No one knew she'd once hunted weaponized pathogens for the CDC until 53 patients arrived with identical symptoms, and she had 30 seconds to say the word no ER doctor ever expects to hear. Bioweapon. Welcome to Hidden Legends. Before we begin this powerful story of hidden expertise and life-saving recognition, tell me in the comments where you're watching from today. And if you believe stories like this need to be heard, hit that subscribe button and help us make sure they are. Memorial Hospital Seattle never slept. Patients flowing through the emergency department, prescriptions being filled around the clock, pharmacy operating 24/7 to keep the hospital running. And working the overnight shift, 11 p.m. to 7 a.m., was Rachel Kim, 38 years old, pharmacy technician for 12 years. Short black hair, wire-rimmed glasses, always in her blue pharmacy coat with her name badge, Rachel K., pharmacy tech. She moved efficiently through the pharmacy, filling orders, checking inventory, restocking medications, speaking only when necessary. The hospital staff appreciated Rachel, but didn't really know her. To Dr. James Porter, the ER attending, she was the tech who always got medications ready faster than anyone else. To the nurses, she was the quiet woman who worked nights and kept the pharmacy running smoothly. To other pharmacy staff, she was reliable but distant, never joining them for lunch, never talking about her personal life. Nobody asked where she'd worked before. Nobody questioned why her medical knowledge seemed deeper than a typical pharmacy tech's. Nobody wondered why she sometimes paused when preparing certain medications, reading labels with an intensity that went beyond routine checking. She was just Rachel, the night shift pharmacy tech, exactly what a busy hospital needed. But young pharmacist Dr. Lisa Chen had noticed strange details over the past 6 months. When infectious disease cases came through, Rachel's questions were unusually specific. She'd ask about symptom onset times, exposure patterns, geographic clusters. Her understanding of epidemiology seemed far too advanced, and once, when a CDC alert came through about a potential outbreak, Lisa caught Rachel reading it with the focused intensity of someone who'd written similar alerts herself. That Tuesday night changed everything. It was 2:17 a.m. Rachel was restocking the antibiotic shelves when her pager buzzed, multiple ER orders incoming. She walked to the computer terminal and pulled up the queue. 7 orders, all for the same combination: ciprofloxacin, doxycycline, and supportive care. All flagged as urgent. Rachel's trained instincts whispered warnings. 7 identical antibiotic combinations at 2 a.m. wasn't random. She pulled up the patient notes, all presented with respiratory distress, fever, chest pain, all within the past 90 minutes, all from the same downtown district. Her hand moved to the phone before her conscious mind caught up. This wasn't protocol. Pharmacy techs didn't call the ER to question prescriptions. But something was very wrong. ER, this is Rachel in pharmacy. Those 7 ciprodoxy orders, can you tell me more about symptom presentation? The nurse sounded harried. Rachel, we're slammed. Can you just fill them? I need to know if they're showing hemorrhagic symptoms. Petechiae, unusual bleeding, rapid progression. Silence on the other end. How did you know that? Dr. Porter just noticed the petechiae. Rachel, what's going on? Rachel's blood went cold. Petechiae. Hemorrhagic symptoms, respiratory distress, rapid onset, geographic clustering. Her mind flashed through differential diagnoses, but one kept surfacing, one she'd spent years studying in classified briefings. Before she could respond, her pager buzzed again. 14 more orders, same combination, same symptoms, same district. Rachel walked quickly to the pharmacy window overlooking the ER. Through the glass, she could see chaos. Patients on gurneys, medical staff rushing, isolation protocols being initiated. 21 patients now, all presenting identically. She pulled up the hospital's infectious disease protocol database and ran a search. Symptom pattern: hemorrhagic fever, respiratory involvement, rapid progression, geographic cluster. The results came back. Differential diagnosis included viral hemorrhagic fevers, but those didn't present this quickly or this uniformly. Her pager buzzed again. 32 patients. The ER was being overwhelmed. Rachel made a decision that would change everything. She picked up the phone and dialed the ER attending's direct line. "Dr. Porter, this is Rachel Kim from pharmacy. I need you to listen very carefully. What you're seeing isn't a natural outbreak." "Rachel, I don't have time for it's weaponized pneumonic plague." The line went dead silent. "What did you say?" "The symptom presentation, the progression rate, the geographic clustering, it matches weaponized Yersinia pestis. Pneumonic plague modified for aerosol dispersal. I've seen this pattern before." "Rachel, you're a pharmacy tech. How could you possibly—" "Because before I was a pharmacy tech, I was Dr. Rachel Kim, epidemiologist with the CDC's Bioterrorism Rapid Response Team. I spent 7 years tracking weaponized pathogens. And what you're seeing right now is not natural. Someone released a biological weapon in downtown Seattle." The ER went silent. Through the window, Rachel could see Dr. Porter standing frozen, phone to his ear, staring at her through the glass. Around him, the ER continued its controlled chaos, but he wasn't moving. 30 seconds passed, then he spoke, his voice tight. "If you're right, we have maybe 4 hours before these patients start dying. If you're wrong, you just triggered a bioterrorism alert that will shut down the entire city." "I'm not wrong," Rachel said quietly. "Pull up the lab results. You'll see elevated white counts, but the differential will be off. The chest x-rays will show bilateral infiltrates progressing faster than typical pneumonia. And if you check the geographic data, all these patients were in the same 3-block radius between 11 p.m. and midnight. That's not coincidence. That's a dispersal pattern." Dr. Porter didn't answer, but Rachel heard him shouting orders. "Get me the hospital administrator, the Seattle Health Department, and the FBI field office. Now. And someone get Rachel Kim from pharmacy up here immediately." Rachel hung up the phone. Her hands were shaking now, adrenaline and memory flooding back. She'd left the CDC 12 years ago after the anthrax investigation that had consumed 3 years of her life. She'd been the lead epidemiologist, tracking weaponized anthrax letters, working 100-hour weeks, watching people die while she raced to identify the source. The work had broken something inside her. So she'd walked away, taking a simple pharmacy tech job where the biggest stress was counting pills and checking expiration dates. For 12 years, she'd succeeded in staying invisible, until 53 patients arrived with symptoms she'd hoped never to see again. Rachel walked to the ER. The automatic doors opened, and she stepped into controlled chaos. Dr. Porter was coordinating with the nurses, setting up isolation protocols, but when he saw Rachel, he stopped mid-sentence. "Dr. Kim," it was the first time anyone at Memorial had called her that. "Prove it. Prove this is weaponized plague and not just a really bad coincidence." Rachel walked to the nearest computer terminal and pulled up the patient data. 53 patients now. She started typing, her fingers moving with practice speed through lab results, symptom timelines, geographic data. "Look at the progression curve. Natural pneumonic plague has an incubation period of 1 to 6 days. These patients went from healthy to critical in under 3 hours. That's modification. Someone engineered this for rapid onset." She pulled up chest x-rays. "See the bilateral infiltrates? They're symmetric, which doesn't happen with natural infection. Natural plague shows random distribution based on inhalation patterns. This shows uniform dispersal, which means aerosol release, probably from a fixed point with calculated wind patterns." Dr. Porter leaned in, studying the data. "You can see all that from x-rays and lab work?" "I spent 7 years doing nothing but this, pattern recognition for weaponized biological agents. This is textbook, Dr. Porter. Someone released modified pneumonic plague in downtown Seattle approximately 4 hours ago, probably using an aerosol dispersal device in a crowded area. Your patients were in the exposure zone." Lisa Chen, the young pharmacist, had followed Rachel into the ER. She stood frozen, staring at the woman she'd worked beside for months. "Rachel, you were CDC?" "Bioterrorism Rapid Response Team, 2008 to 2016. lead epidemiologist on the anthrax investigation, secondary response on 3 attempted biological attacks that never made the news because we stopped them. Why didn't you ever say anything? Because I came here to forget, to do simple work that didn't involve death counts and bioweapon signatures. Rachel turned back to Dr. Porter. But that's not important right now. What's important is that you have approximately 53 patients in the early stages of weaponized pneumonic plague. You need to initiate level 4 biocontainment protocols immediately, and you need to get these people on the correct antibiotic regimen before the hemorrhagic phase accelerates. Dr. Porter picked up the phone. This is Dr. Porter, ER attending. Initiate code black bioterrorism protocol. Lock down the ER, no one in or out. Get me the CDC, FBI, and Seattle PD, and someone wake up the hospital administrator. He turned to Rachel. What do they need? Streptomycin is first line for plague, but you won't have enough in stock for 53 patients. Gentamicin is acceptable alternative. Doxycycline is secondary coverage, but more importantly, you need to identify anyone who was in that 3-block radius and didn't get sick. They're your asymptomatic carriers or your lucky ones who left before dispersal. How do we find them? Security camera footage from downtown businesses, transit records, cell phone tower data. FBI will handle that. Your job is keeping these patients alive for the next 72 hours. The ER doors burst open. 3 people in suits, FBI badges visible. The lead agent looked at Dr. Porter. Who called in the bioterrorism alert? Rachel raised her hand. I did. The agent studied her. And you are? Dr. Rachel Kim, former CDC Bioterrorism Rapid Response Team. Currently pharmacy tech at this hospital. The agent's eyes widened slightly. Kim, you're the epidemiologist from the anthrax investigation. Yes. What are we looking at? Rachel pulled up the data on the large ER monitor. Weaponized pneumonic plague. Modified for rapid onset and aerosol dispersal. Release point approximately 4 hours ago, downtown Seattle, 3-block radius. Current patient count 53, expected to rise as more symptomatic individuals arrive. Fatality rate without treatment approximately 60%. With proper treatment and isolation, we can get that down to 15%. How certain are you? 98%. The symptom pattern, progression rate, and geographic clustering are diagnostic. You need to quarantine the exposure zone, identify all individuals who were present, and initiate prophylactic treatment protocols. The agent pulled out his phone and stepped away, speaking rapidly. The hospital administrator arrived, looking panicked. Someone want to tell me why the FBI is in my ER? Dr. Porter turned to him. We have a bioterrorism event, weaponized plague. Rachel identified it. The administrator looked at Rachel. The pharmacy tech? Former CDC bioterrorism specialist, Dr. Porter corrected, and she just saved approximately 53 lives by recognizing a weaponized pathogen signature that would have taken us hours to identify. 3 hours later, Rachel stood in the ER conference room, surrounded by FBI agents, CDC officials flown in from Atlanta, Seattle public health officers, and hospital administration. She'd walked them through the data, explained the signature patterns, outlined the response protocols. The CDC team leader, Dr. Sarah Mitchell, someone Rachel had worked with years ago, looked at her with something between respect and confusion. Rachel, when you left the CDC, we thought you burned out. No one knew where you went. I came here, to Seattle, to work in a pharmacy, to do something simple. Why didn't you stay in epidemiology? You were one of the best. Rachel looked at the data on the screens, the patient counts, the exposure maps. Because I got tired of counting the dead. In the CDC, every investigation ends with a body count. How many died before we identified the source? How many died during treatment? How many might die in future attacks? I spent 7 years living in that data. And after the anthrax investigation, after watching people die from letters they opened, I couldn't do it anymore. She gestured at the pharmacy beyond the glass. In a pharmacy, I count pills. I measure medications. I help people heal. Nobody dies because I was 30 seconds too slow recognizing a pattern. But tonight, 53 people are alive because you were 30 seconds fast, Dr. Mitchell said quietly. Rachel didn't respond. By 6 a.m., the numbers had stabilized. 68 total patients, all identified, all in isolation, all on treatment protocols. The FBI had identified the dispersal point, a modified industrial humidifier placed in a crowded nightclub ventilation system set to release at 11:45 p.m. They'd arrested 2 suspects based on security footage. The weaponized plague had been confirmed through lab analysis, and the projected fatality rate had been revised down to 8%, thanks to early identification and treatment. Doug Porter found Rachel in the pharmacy, back in her blue coat, restocking the same antibiotic shelves she'd been working on when the crisis began. "You saved 68 lives tonight, Rachel. You would have figured it out eventually." Eventually means dead patients. You figured it out in 30 seconds. Pattern recognition, that's all it was. "No," Dr. Porter said firmly. "It was expertise, years of training, experience most people will never have. You didn't just recognize a pattern, you recognized a weaponized bioterror signature that most doctors will never see in their entire careers." Rachel continued stocking bottles. "I came here to leave that expertise behind, Dr. Porter. The CDC wants you back. Dr. Mitchell offered you your old position, plus a promotion." "I know. I declined." Dr. Porter nodded slowly. "Why?" Rachel stopped, turning to face him. "Because that work requires you to think about the worst things humans can do to each other. Every day you wake up and study death. You analyze how to kill people efficiently, how to disperse pathogens, how to maximize casualties, and somewhere in all that darkness, you forget what it means to heal." She gestured around the pharmacy. "Here, I help people. I fill prescriptions that make sick people better. I count pills that reduce pain. I prepare medications that save lives in normal, everyday ways. That's the work I chose. That's the person I wanted to become. But tonight you were both, the healer and the weapons specialist. Tonight was an exception. Tomorrow I'll go back to counting pills." 3 months later, Rachel still worked the night shift. The hospital had offered her a position in infectious disease. The CDC had called twice more. The FBI had asked her to consult on bioterrorism preparedness. She'd declined everything. But something had changed. The younger pharmacy staff started asking her questions about infectious disease, about outbreak patterns, about public health. And Rachel found herself teaching, quietly, during slow night shifts, sharing knowledge without carrying the weight of official responsibility. One night, Lisa Chen stayed late to talk. "Rachel, can I ask you something?" "Of course." "Do you regret leaving the CDC?" Rachel thought about it. "I regret the circumstances that made me leave, the burnout, the exhaustion, the feeling that I was drowning in worst-case scenarios, but I don't regret finding a quieter way to use what I know." "But you could save more people at the CDC." "Maybe, or maybe I save people differently now. That night, I saved 68 lives because I happened to be here, with this knowledge, at exactly the right moment. If I'd been at the CDC in Atlanta, those people would have died before anyone recognized the pattern. Sometimes being in the right place, even a quiet place, is exactly where you need to be." Lisa nodded slowly. "They're starting a bioterrorism response training program at the hospital. They want you to lead it." "I heard." "Will you?" Rachel smiled. "I'll teach, during my night shifts when it's quiet. I'll train people to recognize patterns, to think about epidemiology, to understand bioterror signatures. But I'm not going back to full-time crisis response. This," she gestured around the pharmacy, "this is my pace now." 6 months later, Memorial Hospital had the most bioterrorism-aware staff in the Pacific Northwest. Rachel had trained 87 doctors, nurses, and pharmacists in pattern recognition, outbreak analysis, and rapid response protocols. She still worked night shifts, still filled prescriptions, still wore the blue pharmacy coat. But now, when infectious disease cases came through, the entire staff knew what to look for. And Rachel had found a way to use her expertise without drowning in it. 1 year after the attack, the FBI closed the case. The perpetrators were convicted. The modified plague strain was destroyed. And Memorial Hospital received a commendation from the CDC for rapid response and lives saved. During the ceremony, the hospital administrator insisted Rachel attend. She stood in the back in her pharmacy coat while officials praised the hospital's quick thinking. Dr. Mitchell from the CDC spoke. This attack could have killed hundreds. The rapid identification by hospital staff prevented a catastrophic casualty event. And I want to specifically recognize someone who chose to use her expertise quietly, but who proved that knowledge doesn't disappear just because you change careers. She looked directly at Rachel. Dr. Rachel Kim, wherever you choose to work, however you choose to serve, your country is safer because of people like you. Rachel didn't step forward, didn't give a speech, just nodded once and slipped out quietly. Because that was who she'd become, not the CDC epidemiologist anymore, not the bioterrorism specialist, just Rachel K., pharmacy tech, who happened to know things that saved 68 lives when it mattered most. So now I ask you, have you ever met someone like Rachel? Someone working a humble job while carrying extraordinary expertise from another life? Write their names in the comments, share their stories. Because at Hidden Legends, we believe the most powerful knowledge isn't always displayed on office walls or spoken in conferences. Sometimes it's carried quietly by the person counting your pills, stocking your shelves, or working the night shift when everyone else is asleep. If this story touched you, subscribe, share, and help keep these voices alive. We'll see you in the next one. And until then, remember, the person in the blue coat filling your prescription might once have saved the world in ways you'll never know. Respect everyone, you never know what expertise they're carrying.